A very good afternoon to the international audience of UAA 2021. Before I debate against robotic-assisted kidney transplantation, I have two disclaimers to make. I'm a big fan of robotic surgery, and secondly, I have been a big fan of our robotic kidney transplant pioneers listed below. They have shown that a robotic kidney transplant can be done with equivalent early graft outcomes as the open surgery. However, just because technically it can be done safely, should it be done widespread in Asia is the question. And when we weigh the benefits against the risk learning curve as well as cost, I think the answer is no. So what are the reported benefits over open kidney transplant, which has set a very high bar? These include by robotic kidney transplant, fewer wound complications, including infections, hernias, and lymphocytes, as well as reduced pain and opiate usage. But as we shall see, are these comparisons with equivalent open transplant patients, or are they actually comparing apples and oranges? Robotic kidney transplant obviously present patients with better cosmesis, but are these the most important things that are cared about by end-stage renal failure patients receiving a kidney transplant? Lastly, they report a transplantation of morbidly obese patients which were otherwise excluded. However, as we shall see, and we know this is being reported mainly only in Chicago by Dr. Benedetti's group and very few other places. A systematic review presented in European Urology in 2017 suggested that robotic transplant may be promising for complications or recovery. However, the evidence is low level because of great heterogeneity in reporting baseline characteristics and perioperative outcomes. Most importantly, in comparison, robotic kidney transplant excludes patients with multiple abdominal surgeries, severe atherosclerosis, complex vascular anatomy in the patient, recipient, or the kidney, as well as patients with advanced polycystic kidney disease. These are all tackled in open kidney transplant series. Nevertheless, comparing 678 open conventional kidney transplant with robotic kidney transplant of 160 patients at the cost of longer operative time and anastomotic rewarming time, the incisional length as well as length of stay in robotic kidney transplant patients are approximately half, 50% shorter, with no increase in DGF and a good incision hernia rate as well as infection rate, almost 0%. However, the data for that was not enough to do a meta-analysis. This was done by a Chinese group in last year, and they showed very similarly at a significantly longer total ischemic time, robotic-assisted kidney transplant achieves a non-significant reduction in blood loss as well as a length of hospital stay after transplant. However, the surgical site infection again was reported to be significantly lower, but as you can see in this diagram, not all studies confirm the significantly lower surgical site infections. So the benefits are at best, between different groups of patients. So balance again, what are the risk and learning curve? We all know robotic-assisted kidney transplant is technically demanding. 35 cases is thought to be the learning curve case numbers. However, these are done or performed by high-volume robotic surgery and transplant surgeons, and this is obviously a rare combination. At our center, we acquired an intuitive grant to develop a porcine training platform for the arterial and venous anastomosis. Although over 4 peaks, we were able to reduce the arterial and venous anastomotic time to less than 20 minutes. The translation from a training platform to real-life experience is a different matter. And here we see the robotic-assisted kidney transplant series in the European experience. 120 cases, mainly living donor transplants of uncomplicated low BMI patients, were performed by very experienced surgeons, including Professor Breda and Professor Alcaraz. And in their series, in the initial learning curve, there were 3 graft losses due to arterial thrombosis, with 4% surgical exploration of bleeding and 4% DGF rates. And this probably is the primary reason our institution has not embarked, despite a porcine training platform, onto robotic kidney transplant, is that we are unable to withstand the loss during the initial learning curve. There are also some complications specific to robotic transplant, including ileus, as well as a lymphocyte, which is not totally 0%. This is a photo of a post-robotic assisted kidney transplant in a low BMI patient. Obviously, the abdomen looks good, but perception of cosmesis is changing. And this is the abdomen, which is equally sexy in the Hollywood actress Sarah Hyland. And these perceptions are changing, and perhaps kidney transplant patients are more taught to be more proud of their wound or proud of their kidney that is donated to them. So the perception of cosmesis is certainly different, although not quantified. And this perhaps teaches us that we need to approach morbidity reduction in kidney transplant patients. ERAS, Enhanced Recovery After Surgery, is well known to urologists. And here at our center, we reported our STAR series, stentless tubeless opposed kidney transplant, where we target low BMI, uncomplicated patients, living donor with no TGF expected. By not using stent, drain, subcuticular skin closure, and good early infiltration of the wound, we are able to achieve early recovery, low morbidity without increasing complications. So perhaps a cheaper way using enhanced ERAS can achieve the same aim as a robotic transplant. And obviously there is no cost analysis, and we expect robotic kidney transplant to be even more expensive with the increased equipment compared to robotic prostatectomy and perhaps robotic partial nephrectomy. And therefore, this is not in line in value-based care that is being pursued at my institution. And here you see our dashboard that looks at clinical quality index divided by cost. There is a range of quality indicators from length of stay to surgical outcomes, including complications, as well as medical outcomes, DGF rate, acute rejection rate, but also looking at patient feedback scores. So this complex index is what we are trying to achieve while we monitor and try and stabilize the achievement of all the quality indicators at the level of cost. So value-based outcome care may be another way of delivering a reduction in morbidity without increasing cost. So in conclusion, what does Asia need? This chart shows kidney transplant activities provided by the WHO. It is clear Asia, outlined in yellow, has far fewer number of kidney transplants per million population compared to the areas in red, America, Europe, and Australia. Asia therefore needs a sustainable model to increase kidney transplantation. Robotic assisted kidney transplant is probably not the answer now, maybe in future, but not now. It may be more worthwhile to focus on enhanced recovery after surgery, to focus on value-based outcomes or care to increase kidney transplant activities in our part of the world. With that, I thank you very much for your attention.